begin to figure out, in a sense, without saying so, budgeting health care by deciding what's going to be funded, to what extent, and what will not. So, by the 2020s, federal funding for Medicaid grow much more slowly, as it will not keep pace with inflation and will have comparative reductions in funding enrollment for the foreseeable future. And this will reduce the number of persons on the Medicaid rolls. The Affordable Care Act, or Obamacare, had market regulations for the private insurance market, including the requirement that insurers would offer coverage to all customers, and had the requirement that insurers charge the same premiums regardless of health status. Now, it has long been an article of faith and operating principle in the healthcare industry, which does say a lot for high level of their ethics, commitment, and dedication to their mission, which really began to take shape in the 60s when health insurance really came into being nationally in this country in the private sector. That means everybody was thrown together in one big insurance pool, and everybody paid basically the same rates, although a little bit of increase for your age and this and that, but not overly. And it meant that older folks who, of course, would develop more and more illnesses, minor and major, as they aged, would not have their premiums skyrocket because there were lots of other people in the same pool contributing, even though they did not have leukemia and this and that. This worked very well and kind of came under the philosophical principle of the common weal, the common good, everyone passively, as it were, economically, helping everyone else, evening out the coverage, and ensuring sufficient funds in the big pot of money to pay for health care for all. Now, the Obamacare plan also required coverage for 10 commonly used services, including hospitalization, prescription drugs, maternity care, and more mental health care treatment. Now, the new legislation and policy initiatives seem to open the door to a weakening of some of these provisions. For instance, states can opt out of some of the requirements if they apply to the federal government for a waiver. And the folks at the Urban Institute, and at this point I'm quoting a Linda Blumberg, who said recently there will be intense pressure for state regulators to do so, to apply for these waivers and be able to opt out or decide to reduce coverage in these many areas to save money. And this would effectively leave people with pre-existing conditions without access to the services that they need. This quote is from Timothy Just, an emeritus law professor and long-term student of mental health or healthcare financing at Washington and Lee University in Virginia. Another area that likely will change, at least some to very drastically, are the standards for out-of-pocket maximums, meaning the caps on how much a person is responsible for on an annual or lifetime basis for their cumulative ongoing health care costs. These caps were banned by the Affordable Care Act because people with particularly expensive conditions could be forced into bankruptcy by their costs. In other words, if you exceeded your cap, then everything else for the treatment of your diabetes or your dialysis or whatnot, that was on you. And if you didn't have $100,000 every 6 months, you were out to lunch and on the streets and lose your house and your car and everything else and end up in the ER all the time. Again, causing health care cost shifting. This bill also would raise the ratio for premiums that insurers could charge older and younger customers. Currently, older customers, such as myself, can get charged up to 3 times what younger customers pay. Now, if you can afford that, I kind of think that principle is sort of fair. Us folks with more stuff ought to pay more. However, for the folks that don't have the kind of income that I have as a physician, and it's really not as much as everybody would think. If I took a poll, 9 out of 10 people would estimate high, but anyway, I'm not in it for the money, as my ethos governs me. But this ratio would increase to at least 5 to 1 for the elderly. So that doesn't look too good, because it also could continue to go up as things change, as revenue streams more scarce, as the policy trend is to reduce spending contained in the philosophy of this bill and in the motivations behind it long term. Now, people who have, in the last 7 years, purchased insurance in the Affordable Care, Obamacare marketplaces get 2 forms of financial aid in order to be able to do so, besides the expansion of Medicare. One is called premium tax credits, which I really have not understood until the last year or so. All these tax credits, it seemed to me like it would be, you get deduction and when you do your taxes at the end of the year, and that never made sense to me, but that was an incorrect idea. This mechanism actually is better than that. I think any healthcare policy plan would be better than dumb bunny ideas probably someone like me would come up with on the fly. But anyway, it reduces the healthcare consumer customers' monthly payments for coverage through these premium tax credits, apparently based on your income and the cost of your insurance. The other mechanism was cost-sharing subsidy, which kept patients out-of-pocket costs for doctor or hospital services, subsidizing these services at the point of occurrence. Now, the Senate bill would eliminate these cost-sharing subsidies entirely. It would keep some of the tax credits, but the maximum income to qualify for tax credits would be reset for 350% of the federal poverty level, which is about an annual salary of about $42,000. Which is lower even than the cutoff for the federal definition of poverty level. This would be kept, but its effect and amount of help would be reduced. Senate bill would also reduce how much of an effect, helpful, that the tax credits would provide for enrollees. The tax credits would be tied to the cost of a less generous insurance plan than under current law, which means if you have a less good plan, in the formulas in this regulation would reduce the tax credits that you would receive, purely on economic formulas and having nothing to do with the health care factors you're dealing with. So for many people who would buy insurance in the marketplaces under this future bill, their out-of-pocket costs would go up, paradoxically, even if their premiums go down. And I think once the voting electorate gets a hold of this, there's going to be a lot of reaction. I can't see how there wouldn't be. Some of the complaints, for instance, about Obamacare had been in the past that the deductibles were too high. But it appears as though from all the reputable, impartial think tanks, healthcare, financing watchdogs, and policy wonks, for want of a better word, have worked out the math, and they all keep coming up with the same end result, that this bill would make deductibles much worse, and that only a minority of younger people might benefit from some of these tax credit changes, but older people will be much, much worse off across the board. Now, this already has been debated in the last week or so, and the prevailing consensus among the non-political analyzing this legislation has been the worry that a lot of people will drop their coverage because of the withdrawal of the many supports for people who could not afford ordinary insurance premiums if they don't have insurance through their employers, and I should have said that much earlier. So there is where part of the 23 million figure comes from. So the other thing is that the bill allows the states to waive the essential health benefits requirement, which means, conditions that are included as things that must be covered. And preeminent among those are mental health and substance abuse treatments, though this new announcement is hopeful, if it sticks, increasing the allotment to $45 billion instead of only $2 billion over a 10 years period of time. Now, I know I've run a lot of quick, fast-paced information past the listener. I hope this has been helpful. I would add the cautionary notes that all this is still way up in the air, even though persons in Congress have stated their hope for a rapid and prompt debate passage of this bill. It looks like it's going to slow down as there is controversy, of course, within the sponsoring party from all sides, and its fate in the present form is really quite unsure. And if I were to make one prediction, I would say what emerges likely, and in my view, hopefully, will be a lot different. But that's going to take an unpredictable length of time, given how Congress operates with committees from both houses, committees of reconciliation, flying ideas before the general public, lobbying, because one of the things that perhaps the Republicans wisely avoided doing this behind closed doors is not having to deal with the lobbyists. Now, as a physician, I kind of view lobbyists as kind of one of reputable occupations in this country, only a few steps above several occupations that I won't mention for fear of getting sued, that are always at the bottom, including some of the folks in the car industry, for instance, all kinds of sales things, other figures involved in the national judicial system, so on. And lobbyists are down there for me. And on a personal note, I kind of view them as on the level of drug representatives who assail physicians' offices who are unfortunately receptive to this stuff, giving away ballpoint pens and all kinds of brochures, and trying to coax physicians into